Good evening, everyone. Welcome to the Snyder Institute for Chronic Diseases Mini Medical School Lecture Series. We are pleased to host a compelling presentation and discussion this evening on the topic of Mapping an Outbreak, Lessons from SeroTracker's Epidemiological Dashboard and Data Platform from SARS-CoV-2 to Zika Virus. My name is Hannah Riley, and I will be the program host for this evening. Before we get started, I'd like to go over a few housekeeping items. There'll be two parts to tonight's program. First, our speaker will speak for approximately 50 minutes, and then we'll open the floor to audience questions. We will take a 10-minute coffee break between the presentation and the Q&A session, and refreshments will be provided to those of you here in person. You're welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or type www.slido into your browser and manually enter the event code SnyderMMS into the participant field to post your question. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they would most like to see asked. Now on to more specific housekeeping items. For those of you who have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link you used to join us at the start. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we ask that you now switch your cell phone to silent mode. Please note, this event will be audio recorded and the recording will be posted on the Snyder Institute website a few days following the lecture. Now, to formally begin our program, the Snyder Institute at the University of Calgary's Cummings School of Medicine, located in the heart of southern Alberta, would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is also home to Métis Nation of Alberta, Districts 5 and 6. And now I'm pleased to introduce our speaker for this evening, Mairead Whelan, who is a co-lead and research manager for SeroTracker project based at the University of Calgary Centre for Health Informatics. SeroTracker project visualizes infection prevalence evidence on an interactive map and dashboard along with its own analyses, working closely with the WHO, PHAC, and other global collaborators during the COVID-19 pandemic to map global immunity. Since then, the project has expanded in partnership with WHO and FAO into multi-pathogen utility for pandemic preparedness for Arboviruses, MERS, and upcoming additional zoonotic diseases. Mairead's research has influenced global vaccination policy, been presented at the World Health Assembly, and has been featured in articles by the New York Times and the Economist. She received her Master's of Science from the University of Oxford and her Bachelor of Health Science at the University of Calgary. Welcome, Mairead.
Is it working? Okay, good. All right, excellent. I'm gonna, I think, camp out over here. Otherwise, I feel like I can't speak to people. So thank you so much for introducing me, and I'm really excited to be here at Mini Med School tonight to talk to you about SeroTracker, epidemiology, and all sorts of infectious diseases. So Mini Med School is in session, and here's a little bit of an agenda that I think I'm going to take everyone through today. So first, I'm going to start off with a little bit of a crash course on how to be an epidemiologist responding to an outbreak and some core terms and what it means to participate in this kind of research. And then I'm going to move into part 2. In a time of crisis, SeroTracker is born. So talking a bit more about the SeroTracker project, during how it came to be during the COVID-19 pandemic, and the kind of research we did mapping the virus. Then I'm going to talk about Arboviruses from there in a different pathogen family, and more reasons why mosquitoes suck. And lastly, finish off with really a kind of call to the future of what that means for the next pandemic. So, yeah, maybe thank you. So starting off, because of course this is Mini Med School, what is epidemiology and where does it fit into what we know about medical research? So when we think about medical research, I like to think about it in terms of what's your unit of analysis? Who's your individual? What are you studying? There's a lot of levels of research that go on, of course, when you think of scientists, you normally think of bench science, petri dishes, laboratories, Bunsen burners. That's not the kind of research I do. You might also think of clinical science, where you work with patients to help heal a disease in people who are already sick. But what epidemiology looks at is, instead of looking at a patient or a cell, your unit of analysis is a population, a community, or a neighborhood as a whole, and studying how disease moves within that population. Okay, thank you. So almost every single epi lecture I've ever been in starts with this story of John Snow and the Broad Street water pump, which is really the origin of how epidemiology came about as a whole, and the first time that mapping an outbreak was used to respond to disease in a population. So in 1854, Victorian London, there was a cholera outbreak at the time when cholera was understood to be communicated by smell in the air. Germ theory didn't exist yet. There's not a lot we knew about it. Dr. John Snow had a theory that perhaps cholera is communicated by water, but no one really believed him at the time. And so what he did and how he proved this using science was to go out in the community during an outbreak on Broad Street, ask people questions, learn about their daily habits, and track the number of deaths going on in the population. Who died from the disease and what was their day? What did their day look like? Who didn't die from the disease and what did their day look like? He put that on a map, all of these little lines representing deaths in the community, and was able to locate the source of the pandemic to a water pump on Broad Street. And he overlaid actually this map of deaths, you can't see it very well here, with a map of the communities in the neighborhood and which water pump was the closest walk from where they lived. And in doing that, he was able to prove the source of the outbreak. And although a lot of people still didn't believe him, the council removed the handle from the water pump. And thus epidemiology was born. And I could really go into detail about this. It's one of my favorite historical topics, but that could take up my whole 50 minutes. But I will say that just last week, I got the chance to visit. I was in UK and Ireland, and I was able to visit the original Broad Street. It was a replica of the pump and now a pub named the John Snow, which I highly recommend. So, mobilizing epidemiology during outbreak, things have changed a lot since the Victorian times. So this does look like, but really what I'm trying to say is the questions we're trying to answer are the who, what, when, why, and how of viruses moving in a population. So we want to know how much disease is out there in the population, who's infected, when did it happen, where is it spreading, how did it transmit, and how did the outbreak begin? And we do this using a tool called surveillance. Sometimes this word causes a bit of an uproar in the general public because people hear the word surveillance and they think 1984 Orwellian, we're being watched. But really, all this means is we are keeping track of what diseases are cropping up in the population so that we can make these kind of inferences and use them for science. So there's two types of surveillance. There's active surveillance, which means that the health agency, the government, is actively seeking reports of cases. So you ask a hospital to say, report to you how many cases of, say, syphilis that they see in a week. There's also passive surveillance, which is simply just collecting reports of cases as they come up through reports and in general public health surveys, research. So those are the two types we'll be talking about today. So now we're becoming epidemiologists. There's a few key terms I'd like you to know. If you remember anything though, I'd like you to focus on prevalence because I'm going to be talking about it a lot today. But when we measure disease in a population, these are some of the really core things we want to know, which is how much disease is out there. So when you look at prevalence, you want to know how many people are infected in your population. So here we've got our population, and we have 1, 2, 3, 4, 5. 1, 2, 3, 4. Okay, good. 5 people. 5 people in the population have been infected with our mystery virus. And when you divide that by the total number of people in the population that you sampled at the time, you get a 33% prevalence. There's also another measure that we use quite a lot called incidence, which is super similar, but a little different, where instead of measuring the total number of cases, you're measuring the number of new cases. So we've added 1 person who's sick here, got sick from the neighbor here. And so that calculation is more like 1 divided by 15, or a 6.6%. Oh, I had it upside down. A 6.6% incidence. And that kind of helps us track how quickly a virus is moving in a population. Again, prevalence is mainly what I'm going to be talking about today. So now that we know what we want to measure, there's a few different ways that you can go out and find this information in the population. So viral testing is really, you're going out and you're looking for the virus. Everyone should be really familiar with this by now, because we've all, I'm sure, done the good old COVID-19 nasal swab test at some point, looking for who's sick with the virus. But you can also do viral testing on things like wastewater to look for viral load and see how much disease is out there. And then you've got molecular testing, which is a bit of an offshoot of viral testing, where you can then isolate the viral DNA or RNA and sequence it. And then you've got serological testing, where instead of looking for the virus, you're looking for the things that the virus leaves behind, which are antibodies. So serological testing is the realm of work that I've worked in over the last several years, and we're going to be talking a lot more about today. But I find that oftentimes serology, serological testing, all of these terms, it's not quite as familiar as viral testing in the nasal swab. So this is a slide I prepared in some jet-lagged delirium to help us understand where we start. So what are the similarities between me and Edward Cullen from Twilight? There's actually 3 answers I'll find acceptable here. The first answer is we're both impossibly fast and strong. Thank you. The second answer is that we're both concerningly pale, which isn't my favorite answer, but I'll accept it. The third answer, probably most relevant here, is that both of us are unusually, more than the average person, interested in your blood. So serological data, at the end of the day, involves blood tests. And so now we're also going to do a mini crash course on immunology at the same time as epidemiology. So when you get sick, floating around in your blood, you've got the virus. So this is a COVID-19 virus, which is covered in these little proteins called antigens. And then your body reacts to help defeat the virus by producing antibodies, which are part of your body, and then they latch onto the antigens and neutralize the virus for you. So where viral testing can tell us, are you infected with the virus right now? Serological testing tells you, where has the virus been? Who has ever been infected with the virus in the entirety of their lives sometimes? And in my area of work, we love to take the word sero, meaning blood, and attaching it to everything. So we know that this particular slice of epidemiology, looking at prevalence, or seroprevalence, looking at the number of people who tested positive for antibodies in a population, serosurveys, seroepidemiology, serosurveillance, and we'll do it with anything, seriously, we'll attach sero to anything. So now you know, if you see sero, it means a blood test. Now, what makes antibody testing really cool is that it allows us to really get a better idea of the true scope of infection in a population, even better than viral testing, which really just show us through lab-confirmed cases what's at the tip of the iceberg. Serological testing can show us cases that went unreported or untested, people with immunity who maybe got vaccinated, and most importantly, asymptomatic infections that would not have been caught by viral testing campaigns. So it really shows us the full scope of what's happening in a population to track the infection and how many people have actually gotten it. Now, this brings us to SeroTracker and the start of the COVID-19 pandemic, when this kind of research was really important because we needed to know how many people actually had the virus. And but there was a few problems we had to take care of first. So I would love to know, in a show of hands, during the pandemic, has anyone here ever gotten a serological test on their blood to test for COVID-19 antibodies? Oh my gosh, we have 2 people. This is more than I thought. Okay, hands up. Who's gotten a viral test? Who's gotten a nasal swab, at-home antigen test? Awesome, everybody. So this is because that viral testing, like PCR and at-home antigen tests, are part of the government's active surveillance program, where they were It was funded, it was for free, anyone could go test it. They were actively seeking out that information. Serological testing was not part of the government's testing campaign. Actually, it was part of almost no government's testing or surveillance campaign. So there was only a few limited ways in which you can get serological testing or even know that it existed. So audience members, where did you get your serological testing? Awesome. So research study, like a cohort. How about you? Awesome. Okay, perfect. This illustrates my example perfectly in that serological testing was really only available to people in a small handful of ways. Number one, you bought a test for yourself at Shoppers Drug Mart for $120. Number two, maybe if you were sick and hospitalized with the virus, they do it to confirm. Or number three, during independent research studies, public health cohorts, public health studies, which is where almost all this data exists. So they're almost all exist in these studies. And so here's how the data actually looks like. We've got all of these researchers who published probably a paper or a report that gives us their seroprevalence estimate in the population. And they can be wildly different, the estimates that we actually see in the papers. Say we've got someone reported a 1% seroprevalence, which is a lot lower than 15%. Maybe someone even reported 99%. This is a bit of an exaggeration to what the data actually did look like, but not as much as you think. It varied really widely. Now, the next question is, why did it vary so widely? First of all, these data are scattered in all sorts of different papers. Each one of these researchers used a different method to collect that information, a different research question, a different study design, a lot of diverse methods, different populations. So maybe the person who found 53% seroprevalence had tested a population of healthcare workers who were exposed in a COVID-19 ward in a hospital. Their rate of seroprevalence is going to be a lot higher than a remote community in Alaska that didn't see the virus for maybe 6 months. Maybe you have this person reporting 99% who sampled their population in 2023 after everyone had already been vaccinated and infected. So we have to dig into each of these studies individually almost to know really what happened here. And this takes a lot of time and is a huge hassle for decision makers who are actually trying to use this data to inform their public health decision making. It's really hard to use to actually make decisions based on this. So that's where we came in as a group. We sat down and we were like, okay, well, what can we do? What can we do to help the COVID-19 pandemic? We were a group of renegade grad students at the time. We wanted to do something. And our advisor at the public health agency told us, we need seroprevalence. We need to understand seroprevalence. Can you guys run a really quick literature review for us and tell us what's going on? And so we did that, and then we kept doing it, and it really snowballed into becoming actually what was filled an important gap and an important resource. So we built SeroTracker to unify seroprevalence data to create one harmonized resource for researchers and decision makers to go to when they needed to access this important seroprevalence data. So we did this by scraping all of those papers, bringing them together on an interactive dashboard. So we operated what is now the largest living systematic review of its kind. So we scraped the internet all over the place for these sources to find these seroprevalence studies for researchers and the public, so they didn't have to do it themselves. We screened 100,000 abstracts and ended up at the end of our review, or after our time running it, with 4,500 studies included in our review from 148 countries around the world, including seroprevalent serological testing data from 38 million participants. So if anyone's familiar with systematic reviews, that's a lot of studies. That's a lot of studies that were published on COVID. And what we did then with our results, which was unique to our group, is we took the results of our living review and we put them online on a dashboard where each one of these dots on our map, this is a video that's not going to work, but you can access it at SeroTracker.com. Each one of these dots on the map is one of the studies included in our database. You can visualize where they are around the world, click on them. It'll show you information to the study. You can click to it and read it yourself. And you can filter through our database with particular types of information. Say you wanted to look at studies specifically in healthcare workers or specifically in children. You could do that on SeroTracker.com and get a custom cut of the data set already cleaned and filtered through right to you. So it saved really a ton of time, and you can go and explore the data yourself. So this really bridged the gap between science and accessibility to the public so that people could actually go into the research and conduct their own research using our data, or really just have a look at the studies and what they meant. But beyond our dashboard, and I'll go a little bit more into the dashboard later, we also used our data to conduct analyses on COVID-19 that informed what was going on in the pandemic. So there's a ton going on in this graph, but really what we can see here is, first of all, in 2020, we estimated global seroprevalence to be at about 5%. This was a lot lower than people thought it was at the time, which made people panic a bit because it meant that 95% of the world was still vulnerable to COVID. But it also meant that the restrictions that were happening in 2020 were working pretty well. Over time, we saw this change a lot. So by 2021, globally, we found closer to 68% seroprevalence worldwide. This is after people had become really infected with Delta. It's after vaccination had started being introduced. But there's kind of more to learn about this when you break it down by region and income level. So these graphs visualize seroprevalence that, so antibodies that were acquired by infection versus vaccination. So you can see in the America's high income countries like Canada, this blue line is vaccination and black is seroprevalence. Most of our seroprevalence was achieved because we got vaccines, we got access to vaccines. And so largely our immunity was vaccine induced. Now, if you look at some of even the low-income Americas or somewhere like Africa, seroprevalence was almost entirely driven by the population being infected. And globally, this is kind of what that looked like. So we were able to really drill down into these differences there. And this is, I think, what I consider to be the most interesting result that we found during the pandemic, which is by comparing the cases we identified in people's blood versus confirmed reported viral cases, we found that we underestimated them by 10 times. So that means globally, for every one case that was confirmed by the WHO, for example, we missed 10 additional cases that were asymptomatic or not reported. And this is a huge number, actually, when we think about it. But this varied a lot by region as well. So in the Americas, high income, like Canada, this number was closer to 2 to 1, which is actually still huge. For every one case of COVID we confirmed, we missed 2. Now, this is what we found in Africa. Do you guys remember in 2020 where there was a whole bunch of articles being like, what's the mystery? COVID skipped Africa. There's no COVID in Africa. It's amazing. It was there. It was there. We just didn't find it. It went completely unreported, and it went crazy in the population. So this was a really interesting result, I think. So these results that we found worldwide went on to inform a lot of really interesting science and policies. We also did some work looking at immunity. So what do these antibodies, what are they doing for us? And do you get better protection against reinfection if you've already been infected or if you've been vaccinated, or both? And we were able to confirm really for the first time that combined immunity between naturally acquired infection and vaccine and being vaccinated provides you the most protection, which kind of provided more reason for you to go get vaccinated. Sorry, I keep holding this wrong. And so this work, along with the slides I just presented to you, informed WHO's vaccination policy directly on booster policy, the spacing of boosters, and understanding really how many people in the world had been infected and when. And so it was presented at the World Health Assembly to WHO's Vaccine Advisory Committee, also Canada's Advisory Committee. And so that was a really cool work to be involved with at the time. So yes, that was very useful for global vaccine policy, but our research had a lot of other user value. So all of our data was downloadable for free and continues to be downloadable for free on SeroTracker.com. So researchers could use SeroTracker data for their own analyses, which is amazing because it makes this science even more accessible to everyone. So we work closely with the Public Health Agency of Canada, Imperial College London, the Robert Koch Institute, which is basically Germany's public health agency. One that I find really interesting is COVAX, which is a vaccine developer, used SeroTracker data to identify vaccine trial sites where seroprevalence is really low. And then we had a few really interesting features in journals, which took SeroTracker data and was able to bring it to the public even further. So the Economist reached out to us in 2021. That was a crazy email to receive, by the way. And they wanted to use a custom cut of our data to understand excess deaths and excess mortality. And seroprevalence data is more accurate to actually understand the true infections. So they used a cut of our data to model infectious deaths in an article, and this model now continues to be used by multiple large NGOs to inform their resource allocation. So I've done a lot of yapping about SeroTracker and its use in seroprevalence in the pandemic and our review to dashboard pipeline, but really this approach is pretty applicable across a lot of variety of topics. So you can study seroprevalence research in other pathogens, and it faces a lot of the same issues as it does for COVID. You can also track studies for viral or molecular testing. You can track studies that test in other species, like animal carrier species or vectors like mosquitoes. Honestly, you can do this type of review to dashboard approach with pretty much anything that has a large body of research. So actually, this is really cool. Also a project out of the Center for Health Informatics, like SeroTracker, a group who studied ACEs, which is adverse childhood experiences, so kind of psychological public health studies on kids. Saw SeroTracker's approach, said, hey, there's a huge body of ACEs research out there. And now they've published a similarly inspired catalog on ACEs research that you can see on aceshub.com that follows really a similar approach. So very cool to see that applied elsewhere. And really the point here, beyond the epidemiology in SeroTracker, is that there's so much valuable research data that goes unused or isn't available or accessible to the general public. It's buried in academic journals, behind pay firewalls. It's hard to understand, it's hard to read, and it ends up kind of being wasted. Research is published in academic publication, may be accessed by only a few researchers, and it's outdated as soon as it's published. Reporting is low, and approaches like SeroTracker that help elevate science and bring it to the general public so we can use that data to inform decisions and inform our day-to-day is super important. So I won't go into detail too much about this, but another branch of the work we did at SeroTracker beyond the cool epidemiology is thinking about this approach to evidence synthesis and how we can do it better to tackle health problems. So we use natural language processing to help speed up the screening process. We automated our critical appraisal and portions of the systematic review. And our recent foray has been into AI, as with most people in the world. But we're really thinking now about how we can use AI to automate systematic reviews and do them for us, which would speed up the massive human resource load that's required for these immensely and bring evidence to the forefront of pandemic preparedness right away. So we've designed a prompting framework that uses AI to screen abstracts for systematic review, which usually can take weeks or months. And AI can do it in a matter of minutes. And we found with our tool about 90% accuracy, which is similar, if not better, than a human reviewer. So we're very excited about that and hopefully bringing it into our next area of research. But now switching gears a bit, because I've made the case for how SeroTracker and this approach can be applied elsewhere to other pathogens or other topics. That's kind of exactly what we did. A few years ago, we thought about, okay, well, let's see if we can do this somewhere else. And we ended up landing on Arboviruses, And this is where I go into the portion of my talk where I give you a couple more reasons to dislike mosquitoes. So this is probably my favorite public health related meme, so I had to include it. But arboviruses are diseases that are transmitted by biting insects like mosquitoes and ticks, midges. There's all sorts of them out there, but the most popular one is mosquitoes. And unfortunately, their range is increasing due to climate change. Mosquitoes, they're creeping further and further north, the ones that capture these diseases. And so it's really at the forefront of something we should be concerned about. Also for people who travel would likely encounter these diseases. So it includes Zika. People may be familiar with this as there was a big outbreak of it in 2016 where we realized that Zika, which is largely an asymptomatic disease, it doesn't make you that sick to have it, but it was contributing to microcephaly in infants. We have yellow fever. West Nile is an arbovirus that's in Canada. Chikungunya, Mayaro, Rift Valley fever, Oropouche. Lyme disease is also an arbovirus, but I'm not going to be talking too much about ticks today, partially because I'm really scared of them, but mostly just because I studied most these guys up here. So one thing to note is that despite this name, malaria is not an arbovirus. It's not a virus at all, actually. It's a parasite, which is not really common knowledge because you hear about it a lot. And it's actually carried by a completely different type of mosquito. And so therefore it requires different intervention strategies than malaria, which is why we have to study these a bit differently. So I'd like to introduce you all to a concept called One Health, if you aren't familiar with it, which is really, I think, the future of public health, in where we need to start considering health at the intersection of animals, humans, and the environment, and the world that we live in as a whole. Our health is very interrelated in all sorts of ways, not only for these examples here, but in ways we can't even begin to comprehend. And while we have concurrent crises going on, like climate change, loss of biodiversity, increasing population, an increasing need for mass agriculture, these issues are only going to become larger. So vector-borne diseases like mosquitoes are one of these, a classic example of this, where we need to be considering all of this together in order to tackle the problem. It also includes antimicrobial resistance, zoonotic diseases that pass from animals to humans, climate change, food, agriculture, there's a lot. And there's a lot to think about when you tackle these. Which is why arboviruses require tailored epi approaches and have several important challenges that we need to be considering. So dengue, I know the title of my talk said Zika, but actually I'm going to be talking a lot about dengue. Hope that's okay with everyone. But it's a very interesting virus. And there's a multi-country big outbreak happening in 2024. There's a lot of cases happening in this worldwide, and we don't talk about it too much. But arboviruses, one of the big problems is that, especially in Africa and Asia, they're really all the time misdiagnosed as malaria. When the diagnostic capacity is not as equipped, so in areas like Africa and Asia, when you have a disease, a febrile disease with fever that presents, actually a lot of arboviruses have really similar symptoms to malaria. They look exactly like malaria. So they're just diagnosed as malaria with no testing, which means we don't know the true number of cases of arboviruses that are actually circulating out there. And that's a problem because we treat them differently. They're strongly dependent on environmental conditions, climate change, weather and rainfall patterns, and One Health as a whole. Arboviruses require different public health responses than malaria, and also between each arboviruses. So we have to consider that dengue, for example, is a day-biting mosquito, whereas malaria is a night-biting mosquito. Some species of mosquitoes breed in different environments. Some of them prefer ponds, others prefer shallow little pools of water in potholes. And sometimes some of them are carried by other animals too. So we need to know the problem in order to treat it. And right now we don't. And what can we use to do that? Seroprevalence studies, because where viral testing is unavailable, seroprevalence can tell us a lot about how much disease is circulated in the population. So for that reason, arboviruses use seroprevalence studies for a lot of the same reasons as COVID, but they have even more applications actually in some cases. So talking about dengue virus, it's actually a really interesting virus, but it's super weird in that it has 4 types and they all circulate together at the same time. And the way dengue works is the first time you get infected with dengue, you might feel kind of sick. You don't feel good, but then you get better and you kind of move on. If you get reinfected with dengue, with any of the other serotypes, any of the other types of dengue out of the 4 that are circulating, which is highly likely that you will, you get really sick. You get super, super sick. Your fever is extremely high. It causes muscle seizure, death. The morbidity is much, much higher. So that really complicates things. So actually, the World Health Organization recommends that dengue vaccination, and there is a vaccine, only begins when population seroprevalence hits about 60%. And this is because, if you get infected and infected again, you're super sick. Interestingly, the dengue vaccine elicits a similar immune response to your first infection. So if you're vaccinated and then you get infected, you're really sick. But if you're infected first with that really mild form of dengue, and then you get vaccinated, you've got lifelong immunity. So we need seroprevalence studies to know how many people have been infected before we can even go in and start vaccinating. And yet still, like COVID, all of this data exists in academic publications. They're hard to access. How do we use it? So there's delays in results. There's a lot of species that are infected, so it can infect dogs, cats, pigs, livestock. And also another issue specific to arboviruses is they tend to cross-react on lab tests. So a test that's positive for Zika virus might also falsely test positive for dengue and chikungunya and all of them. So there's like a lot of diversity in the tests and results because of that. So we took SeroTracker and we did almost the same thing, but we tailored it specifically to a lot of these One Health use cases. So our new ArboTracker database, which I'll pop a link up somewhere. You can access all of our dashboards online. I do encourage you, by the way, to explore it. We now have 6 of these pathogens on there. We have all of our filters you can go through. You can download the custom data set on all of these different arboviruses, and we update it biannually because the data is published slower than the COVID data was. So moving in through a few use cases of our dashboard, including the ArboTracker dashboard, that we found have provided value to policymakers and scientists. So first of all, is exploring seroprevalence data in a given country, region, sampling date, or sampling frame. So say healthcare workers, children, etc. You can zoom in on a single country. This one is Brazil, looking at Zika estimates over time or in different studies. So we can see some studies are presenting higher estimates than others, depending on the population. And we also provide 6 or more figures like this, which adjust according to the filters on the side and the studies that you've selected. So you can go in and right away analyze results across all of the studies you've included in the database and download them, which is helpful for PowerPoint presentations. So another thing we did is that we took environmental maps for mosquito habitability, essentially, like where are their habitable environments for them to live. And then we can map these seroprevalence studies against these areas where dengue, I think this is our dengue map, dengue mosquitoes live. And then we're able to visualize where there might be huge data gaps that we haven't investigated yet that we probably should be investigating. For example, this whole region in Africa has 1 seroprevalence study, and there's a lot of mosquitoes there. We might be missing studies. So it kind of provides a basis for researchers to understand where there might be things that we need to do more work on. And we also mapped, so we have maps for Zika, and then projections for 2015 and 2050 for dengue as the mosquitoes move. So really probably the biggest use case is that this allows researchers to complete a background literature review for their papers in minutes, as opposed to hours or weeks, like it usually does when you're doing a background literature review for your paper or grant or whatnot. So you can look in the filters, find studies specific to, say, children or youth, men or women, test information. We even have information on the lab tests that were used, and drill down to a specific subset that's comparable and synthesized and downloadable right away. So what does this look like behind the scenes? Basically, what we do is we use a tool called Covidence to do our screening. We hop in there, we screen through all of the thousands of studies that are presented to us as maybe being eligible, and then we get rid of all the ones that aren't. Once we've done that, we upload them to our database. It's hosted on a server called Airtable, and this is where our researchers go in, work with the data, clean it, arrange it, so it's all in these lines where it can be comparable to one another. And then we pipeline that data with a team of software engineers working together with epidemiologists onto a dashboard that is designed in really collaboration. It's one of the things that makes us unique, I think, is that we have software engineers part of our research lab, which isn't the most useful, or it is very useful. It's not the most usual. And that's how we work. So that's a little bit about arboviruses, but what's happening in the future of public health and tools like SeroTracker, where do we kind of go next with this? So there's lots of things going on in the SeroTracker multiverse. I didn't speak about it too much today because I can't tell you about every single disease in the world in 15 minutes, but we also have another tracker where we visualized both serological and viral data in animals and humans for a disease called MERS, or Middle East Respiratory Syndrome, which is another coronavirus, but nobody freak out. It's been here for a long time with us. And its primary reservoir is camels, and it passes from camels to humans sometimes. But when it does, it has very high mortality. So we're a little worried about it. We like to keep an eye on it. So we work together with the World Health Organization and the Food and Agriculture Organization of the United Nations to put together our MERS tracker dashboard, and you can see a map of camel density in the background. So that's another thing that I'd encourage you to have a look at, and I'm happy to answer questions about. We're leaning more into AI and how we can conduct extraction of full text, which will bring us hopefully to an end-to-end automated systematic review. So this data work that feeds our dashboards can be done almost live, which is exciting. And to make it even more efficient and sustainable. Because in a pandemic, the most important thing is time. And you don't want to be spending time doing a review. So hopefully this will be improved for next time. And looking forward, we're hoping to continue expanding the MERS tracker alongside WHO and FAO. They also have come to us with interest in expanding into Rift Valley fever, which is another arbovirus, and avian influenza. We're looking to work with the Vet Med School here at U Calgary on putting together a tracker for antimicrobial resistance studies, which is another big One Health problem, and continue really that SeroTracker and U Calgary innovation in that space. But that's a very sort of localized to what we're working on. But what did we actually learn in terms of challenges that we need to overcome for the next pandemic? Because there's probably going to be one. I really hate to break it, but as climate change increases, encroachment on biodiversity, population density increases, we're likely going to see them again. And we have already, in fact, since COVID. So what we really need is timely data sharing and opportunity for direct result submission so that when we have seroprevalence data, we can access it faster and a lot easier. We found that there was about 3-month delay between when blood samples were taken and those results became publicly available, which meant we didn't get them until 3 months later, which in the scope of the COVID-19 pandemic, there's a lot happening in 3 months. You know, we'd update our data and then Omicron appeared. And then our results were out of date. Actually, that's it. So do you guys remember, I should have said this earlier, but do you remember when I said that cases were underestimated 10-to-1? That actually was a result that we found before Omicron happened. And so we published that result. It was really cool. Then Omicron happened, and probably that number was blown right out of the water with how many cases we missed. So things were out of date right away, and we need to improve that. Rapid evidence synthesis to compile important findings quickly. I've spoken about that already. Utilizing knowledge translation to elevate science so it's accessible to the public and professionals so that people are able to access peer-reviewed science that is maybe not off Facebook.com and helps better inform people on really what's going on in the world of science and how to trust it more. Investment in robust early detection surveillance systems and public health networks so we can identify early outbreaks as they're happening instead of after. And cooperation between countries, public health researchers, policymakers, health agencies, engineers, veterinary scientists. It's a whole world that we need to work together on really closely in order to make this happen. So forgive me for getting a little bit political for this next slide, but protecting public health and science is more important than ever because there's been really a lot that's happened in the last 3 weeks down south. So I'm going to click through a few headlines just to talk a little bit about this. We've had the United States exiting WHO. We've had the CDC staff ordered to cut off communication with WHO down south. We've had the US health agencies like CDC told to stop their reporting, and that includes reporting on cases of important diseases like avian influenza, foodborne illnesses, circulating flus. An exit of USAID, which is a huge pillar of global health for these protecting the health of citizens all over the world, not only in our countries. Federal funding freezes, withdrawing papers to hunt out forbidden terms like gender, transgender, non-binary. And then lastly, cutting huge cuts to funded research at NIH. And this is all happening, of course, to the south of us, but it's important to take a moment to pause and think about what this impact is going to look like globally for public health and how it could reach us. It's already reached my group, for example, because we are funded and work directly with WHO, and our funding has been impacted by the funding pauses. And, you know, really, it's kind of overwhelming sometimes. So what can we do in this era where public health is more important than ever? And we need to really protect ourselves and be able to detect these diseases. So what can any of us do is take a moment and stand up for science and research and think about and advocate for why it's valuable. If you agree with me that public health and epidemiology should continue to happen, write your representative to reaffirm your support of investment in public health research, keep engaging curiously with research like yourselves, come to lectures like this, small acts of kindness and seeking joy, especially for folks who are impacted, and voting in an upcoming federal election. And I will add a final caveat that my views are my own. And while I work with WHO and PHAC and a few foreign agencies, this is entirely my own views and opinions. So take that as you will. And that's really what I want to end my talk on. I'm about 50 minutes on the dot. I'm really impressed with myself for that. And thank you so much to our wonderful team partners and funders from 2020 to now and beyond. I have a fantastic team who put together everything really we've seen here, including some slides and a few resources and references. And then finally, the link to our website so you can explore all our dashboards, my contact information if you'd like to ask questions. And yeah, I'll hand it back over to the organizers for Q&A.
Awesome, thank you so much. That was a wonderful presentation, Mairead. Thank you. We'll break now for about 10 minutes for coffee and snacks, and then we'll return to do our Q&A session. All right, welcome back, everyone. I hope you all had the chance to grab a snack and a drink. We'll now open the floor to our question and answer period, and we'll do our best to alternate between questions from our virtual platform and our live audience members. As a reminder, questions can be submitted virtually through Slido by scanning the QR code or by opening www.slido.com and entering the event code Snyder MMS into the participant field. For our live audience, please raise your hand, and if you have a question, and someone will provide you with a microphone. We'll do our best to answer as many questions as we can in the time remaining. So we don't have any questions on the Slido yet, so if someone from the audience has a question, feel free to raise your hand, and we can get to you. If no one has a question, I'll ask you something to read. So I was curious, for dengue virus, since you get so sick the second time, is there like a specific mechanism? Do you know why reaction the second infection is so much stronger?
Yeah, so I'll start off by saying I'm actually not a virologist. So I'm not actually super sure how it interacts to make it that way, but I think it's because there's 4 types of the dengue virus. They're actually called serotypes. They exist in your blood. Again, sero added onto anything, it has to do with your blood. So it's just really the way that it activates your immune system and how the 2 types of virus kind of react against each other. And I'm not actually sure the exact mechanism for why that happens, but I will have to look into it now because actually I'm quite interested in it too. But yeah, it has interesting epidemiological impacts.
Okay, well, thank you. Anyone in our audience have a question? I'll just repeat the question quickly. So the question was, how do you differentiate between people who have been naturally infected by a virus and people who have been vaccinated?
Yeah, that's a fantastic question. And that kind of, you dive a little bit more into immune science as to why that is. So most of the vaccines that were on the market, especially in North America, we know them as, the Moderna and Pfizer viruses are mRNA viruses, which means they were basically trained to react to a specific antigen, like a specific protein on the surface of the COVID-19 virus called the spike protein. And they're well named really because they're the spiky ones. Whereas there's really a lot of antigens on the surface of the COVID-19 virus, a particular other one is called the N protein or nucleocapsid protein. But so when you have an immune reaction that produces antibodies based on one of the vaccines, it produces anti-S antibodies, but not anti-N antibodies. Whereas a natural infection produces both of those types of antibodies. And you can actually have different kinds of laboratory diagnostic tests that look for S versus N antibodies. So essentially by testing for both of those, we can see that someone who has S antibodies but no N antibodies has been vaccinated but not infected, whereas someone who has N antibodies and S, all of the antibodies, has likely been really infected. So it's not a perfect method because there are some vaccinations that elicited a more total immune response, like the Janssen vaccine and oh my gosh, AstraZeneca was another one. Elicit some more total immune response. So it's not 100% perfect, but it produced some. Yeah, you could pretty much go in find out just by the type of test whether it was a vaccine induced or infection induced. But we also overlaid our data with vaccination data from a database called Our World in Data to supplement and try and fill those gaps where maybe countries had used mainly the AstraZeneca or Janssen, for example. So that's how we did those analyses.
Thanks. The next question is, are there many studies that look at cultural sociology alongside epidemiology?
Oh my God, yes. I mean, yes, absolutely. There is actually a whole branch of epidemiology called social epidemiology, where you dig into the social determinants of health and a lot of really like the social factors that are at play in determining a disease. So for example, kind of income level or housing situations, gender, what job you have, your lived experience, your childhood experiences, all of these things impact the distribution of diseases in a population, and you can study those. So there's I think it's actually extremely huge part of epidemiology and public health as a whole. Yeah, very, very cool research.
So anyone else in the audience have a question? We'll go here first and then there. So just shout it out and I'll repeat the question. So the question is, do you see a Lyme tracker soon?
I have looked into working. Oh, okay. I have looked into the possibility of a Lyme tracker because definitely that's a big one in Canada. Is of course huge presence of Lyme disease here, and got a lot of ticks. It freaks me out every summer I go hiking. But from what I've looked into it so far, there's not actually that many seroprevalence studies that have been done that test for Lyme disease, which is really interesting considering it's such a big. Yeah, you can test for Lyme using a serological test. Actually, I think the confirmatory test they've used for some Lyme disease is a blood test. In some cases, it's not a perfect test either. So there's a few barriers in creating a tracker for Lyme if there's not enough studies or enough tests, like you said. But I hope I would like to involve more ticks. I think that's such a huge vector that there's obviously so much epi research that's to be done there. So yeah, in short, I would love to do a Lyme tracker at some point. We'll see. Maybe I'll apply for a few grants and see what's kicking around there.
I think we had a question from the back of the room there.
Yes. Oh my gosh. Yes. The differences in the data makes it super difficult to standardize and then actually compare and analyze appropriately. So we can do as much as we can with a literature review and something like SeroTracker, but there's still a huge amount of diversity in the data that stops us from being able to fully analyze it. So the ideal situation is exactly what you said, like taking a box to use your residual bloods for testing. And that's actually something, so SeroTracker, we were part of this coalition during the pandemic called the COVID-19 Immunity Task Force, which was kind of a funding body that was funded by the Public Health Agency, and with a whole bunch of people in Canada doing immune studies. And as a few years ago, we kind of got together as a group and had basically that idea, which was how can we use residual bloods that are left over from routine blood testing, and we were working with Canadian Blood Services as well. And for blood donations, how can we take a box to do routine serological testing for COVID and a whole bunch of other viruses too? I think are these wasted bloods are a huge untapped resource that we could be using for population surveys. Not to get into the details too far with it, but we started running with this idea and then encountered a lot of bureaucratic red tape about whether or not it was actually possible between all of the provincial laboratories communicating with one another, then Canadian Blood Services communicating with the provincial laboratories, and then the Public Health Agency of Canada saying, wait a minute, that's our job, we should be doing that. And then but then they don't actually want to do it. So there's so little funding that goes around in the public health world. It's something they would like to have happen, but priorities get pulled all over the place. So I would love to see that happen one day. Oh my gosh, that would be so great. So I hope that one day we can see that exactly something like that happen.
Awesome. The next question is, do you have any upcoming goals / new developments for the SeroTracker?
Yeah, definitely. So yeah, like I noted this a tiny bit in my talk. So one of the things we're really excited about is continuing to use AI to train AI to run our systematic reviews for us, which has gotten a fair bit of interest. We have an actually upcoming paper that's going to be published at the end of the month that describes this tool and how researchers can use this tool in their own research, because we actually trained the tool across 10 different data sets, including our own, plus 9 other data sets that weren't related to seroprevalence at all, to show that we could use our tool for a variety of health research reasons. So we did that for screening. We're hoping to expand the tool so it's possible to use across the full slate of things. I think this is the kind of thing that I'm excited about AI being able to do, because literature reviews are a slog. Oh my gosh, you don't want to do them. They take so much time. They can be a little bit menial. So having AI do something like that would be a huge, huge help. And so we're excited about that. And then the other thing is hopefully expanding into the world of more trackers. If I could have a tracker for every disease, I would do it. But unfortunately, there was only so much time. But yeah, so hoping to expand into Rift Valley fever and avian influenza is one I'd be really interested to expand into. That's kind of on causing some early warning bells right now. In the flu world, testing in birds and humans and livestock that are being infected, and understanding how we can mitigate that using tracking evidence. Those ones are a little bit dependent on the WHO and FAO situation with their kind of funding and what projects they're going to end up going ahead with. But I would love to do avian influenza anyways. And then antimicrobial resistance is the other one that's on the agenda for us, hopefully in the new year. But yeah, those are, and then continuing to expand our Arbovirus program as well. Adding more viruses to that, adding more capacities to that, hopefully speaking to, and our Middle East respiratory syndrome, our existing trackers, speaking to people who use them, talking to WHO, talking to scientists, seeing how we can improve them, expand them, all of that. So that's kind of on the immediate, hopefully near future agenda for us, probably within the next year.
Great. Does anyone else? Oh, we have a question over there.
Before my main question, can you just remind me what FAO is doing?
Oh, sorry. Yes, it's the Food and Agriculture Organization of the United Nations. So it's like WHO is a branch of the UN, but they deal with food and agriculture and livestock. And when it comes to public health, they deal with diseases in animal populations. So any disease that's ripping through livestock, animal populations, they are the branch that deals with that. But of course, this is super important for to engage with them when you're engaging with like zoonotic viruses.
Thank you.
Yeah.
But the next question I did want to ask was that have you built in any sort of error analysis following on that question just now that the spread of numbers that you got? I would have thought it's very important to know, are we accurate within this percentage for that percentage? You know, assuming a Gaussian distribution and not assuming a Gaussian distribution, looking at the you know, a broad and narrow analysis that you can put in.
Yeah, absolutely. Actually, can everyone hear the questions there? Okay, you got you. Yeah.
Yeah, the question was about if there's inbuilt error analysis in the SeroTracker tool.
Yeah, so the answer to that is yes, and that's actually a concern that we spend a lot of time dwelling on, is that we've compiled all of this data from all over the place, but all data is great, but some data is better than others. Basically, there's varying qualities of what's reported, the quality of the study that's been presented. Some methods are more scientifically sound than others, and so we have problems when we mash them all together and try to make inferences from them. So that's where this kind of analysis comes into play. So one of the things we did is we added a step in our review called critical appraisal or risk of bias rating. So each one of our reviewers went into every study in our database and evaluated it for how high, basically the quality and reliability of those methods. So all the studies in our database for our COVID-19 tracker got rated at either a high, moderate, or low risk of bias, the low risk of bias being the ones that are kind of the gold standard of methods that were used. So that's one way that you can go into our database and find out, which studies are going to have the most reliable evidence. So for some of our analyses that we did, so the analyses on seroprevalence that I presented, a lot of those we actually decided to restrict to only the low risk of bias or moderate risk of bias rating studies. So we knocked out the ones that had that we determined were at high risk of bias. so that our analyses that we were presenting to WHO and policymakers were coming from the best evidence possible. And then the next thing that we did is that for things like assay and diagnostic test reliability, we made a catalog of all of the different tests that existed and their performance measures, so how accurate they were. And we were able to go in with our data and using a little bit of statistical magic, adjust the results that we got so that it accounted for some of the errors in the laboratory testing and some of the population. We also adjusted statistically for some of the population sampling biases that may have been introduced as well. But even then, it's still not perfect. You still encounter these issues, which is why standardized research that was brought up earlier on, all the same methods, same sample is like what every scientist would love to have in life, but it's usually not possible. So we do our best in the meantime.
Okay. Our next question is, can these tools be used to track the more common childhood diseases in North America, such as measles or chickenpox? And that might influence vaccine hesitance.
Yes, yeah. So there's a ton of seroprevalence studies in measles, chickenpox, really a lot of infectious diseases. Most infectious diseases, you can use seroprevalence studies to track and identify them. Measles actually has a huge body of research in seroprevalence literature. And it's quite interesting because similar to COVID in the question earlier, you can actually differentiate between antibodies induced by infection and antibodies induced by vaccination in a slightly different way. It's just because infection with measles produces like astronomically more antibodies than infection induced. So just by looking at the quantity of antibodies in your sample, you can tell whether someone's had measles or not. So it's pretty cool. There's a lot of research there, absolutely. And influencing vaccine hesitancy, I mean, that's a whole other can of worms, to be honest, that can be unpacked, but hopefully, seroprevalence and epidemiology and some of these studies can have a role in talking about the way vaccines work inside our bodies and why it's really not as scary as some folks might think.
Does anyone else in our audience have a question?
Mm-hmm. Do you want to repeat? Okay, so the question was cross-reactivity between arboviruses in testing and kind of why it happens. Does that summarize it well? Yeah, exactly. So yeah, is there ways to, if they do cross-react and do further testing? Yeah, definitely. So they just tend to cross, they're very similar viruses. So they present just in the way that they're structured quite similarly to each other. So sometimes one antibody can react to antigens across a couple of them. And they can kind of slot into those proteins well, which is also for the same reason why we find cross immunity between certain viruses, for example. So some coronaviruses, for example, you can get one coronavirus, there's some evidence that shows that if you've gotten MERS or gotten the coronavirus, you might be more immune to MERS or another coronavirus than someone else. So it's for the exact same reason why they cross-react with each other on an antibody test, because tests are kind of designed to mimic your immune system. So can we do more tests to find out what the truth is? And the answer is absolutely yes. So if you have one test that has a tendency to introduce some cross-reactivity, you can add another different test onto that. And you can add another different test onto that if you want. There's loads of different types. You can do an ELISA, you can do an immunofluorescence assay, you can do a antigen test, you can do a neutralizing test. These are all sorts of different lab tests that do the same thing, which is identify antibodies, but in different ways. So if you stack them on top of each other, definitely you can get to the bottom of it. And a lot of the best research studies do exactly this, so that they confirm what the true positivity is, but it's really expensive, which is the problem, especially if you're in a low resource setting, like in developing countries, you might only have the budget for rapid tests. And rapid tests are the least reliable, but they are the cheapest and most accessible and easiest to run. So, yeah.
Yes. I think we had a question over here.
Oh, the quadrants of Calgary. So the question was the cultural and epidemiological data across the different quadrants of Calgary. I have no idea. I don't know, actually. What I would love to pull up for you right now, and I do know is it should be on SeroTracker.com. If you go to our website and then you narrow it down geographically to studies in Calgary, you can click through them and see exactly what they analyzed and whether or not they broke down their data by community. Our analyses were focused on a bit more of a global scale between different parts of the world. So we did not do that analysis ourselves, but I know that there are lots of cohorts that did sample people from Calgary that did serological testing that hopefully would have information like that. And they usually in a lot of serological studies will include cultural aspects as well, like what your job is, where you might have been exposed, income level, education level. It really varies very much depending on the study, depending on what the researcher decided that they wanted to add into their investigation. Some of them just reported a pure prevalence statistic. Some of them added in a lot more consideration with the cultural variables. So that was another thing that varied a lot. But yeah, I would super encourage you to check that out to answer your question between the quadrants, because I don't know, unfortunately, but probably interesting.
All right, so we're out of time for tonight. But before we go, I just want to say thank you to our speaker, Mairead Whelan, the Snyder Institute for Chronic Diseases, BHSc, the Cummings School of Medicine, and each of your audience members for attending tonight's Mini Med School lecture, especially considering that it's so cold for those of you here in person. We hope that you thoroughly enjoyed tonight's session and invite you to join us on March 3rd for our next Mini Med lecture on prion diseases. Thanks for joining us and have a great evening, everyone. Yeah.